Welcome back. Let's dive right into this explainer on cerebrospinal fluid shunt devices. If you're looking for a resource that completely clears up these concepts so you don't have to go endlessly digging through textbooks, you are in the exact right place. We're going to examine the hardware, their unique physical properties, and the precise patient care protocols step by step, skipping absolutely no detail.
Here is our roadmap for today: the Hakim valve mechanism, the Integra horizontal vertical lumbar valve, Holter valve specs, the Salmon-Ricken reservoir, and finally those absolutely essential patient instructions.
All right, kicking things off with Section 1, the Hakim valve mechanism. Take a look at this custom watercolor theme diagram we put together. It perfectly breaks down the Hakim standard valve without being overwhelmingly clinical. You can see the fluid flowing from left to right, hitting the antechamber first, then moving through the primary body. That body houses two distinct one-way ball valves, with a pump chamber right in the middle. And notice how each functioning segment is totally isolated inside that celastic housing. It's like a perfectly compartmentalized little engine.
Now here is a massive distinction you need to burn into your memory. There's a strict operational rule on where you pump versus where you tap. To manually pump the shunt, you only press the pump chamber nestled between those two ball valves. But if you need to tap the device for fluid access or pressure readings, you absolutely must exclusively use the antechamber positioned upstream. No exceptions.
Why no exceptions? Because, and this is a critical warning, if you tap the pump chamber, you ruin it. That silicone elastomer housing is not self-sealing. If a needle goes in there by mistake, you've literally created a permanent mechanical failure. We're talking a potential full surgical revision just because of a misplaced needle. That's exactly why mapping out these points visually is so incredibly vital.
Moving right along to Section 2, the Integra HV lumbar valve, which is all about dynamic pressure control. This specific device is a real game changer for lumboperitoneal shunts. It elegantly solves a huge problem: gravity. Think about it. You've got a column of fluid running from the lumbar spine all the way down to the peritoneal cavity. When a patient simply stands up, boom, you get a massive siphon effect that can cause dangerous overshunting. This valve acts as a clever countermeasure to fight back against that gravitational pull.
And our next watercolor schematic shows exactly how it pulls this off. It uses gravity against itself. When the patient stands upright, these three little internal weighted balls drop down, hit a nozzle, and drastically crank up the resistance to fluid flow. But when they lie down horizontally, the balls just roll out of the way, resistance drops, and fluid drains normally. It is such a brilliant, purely mechanical solution.
Of course, because it relies heavily on gravity, implanting this thing upside down or backwards would be a total disaster. So the hardware gives you built-in, redundant physical cues to get it right point by point. First, look for the visible flow arrow on the inlet side. Second, the inlet tubing itself is physically clear. And third, that clear inlet tubing is noticeably narrower than the outlet tubing. Continuing with those fail-safes, the outlet tubing is bright white, giving you a stark, foolproof contrast against the clear inlet. Finally, the protocol dictates that you have to fully connect the valve to both the subarachnoid and peritoneal catheters before you permanently suture it down to the fascia. Oh, and you have to make absolutely sure that flow arrow is pointing straight toward the patient's feet, or the gravity trick won't match their upright posture.
Okay, Section 3. Let's look at the Holter valve and its unique physical properties.
As you can see in this watercolor rendering, the Holter is a bit different. It uses a dual-slit valve mechanism. Fluid comes in from the left, pushes through the first one-way slit valve, enters that central celastic pump chamber, and then pushes out through a second slit valve on the right. To manually pump it, you just depress that squishy center. It's also usually paired up with a separate reservoir upstream so that pumping and tapping stay completely, safely separated.
Now, when you're actually holding this valve during surgery, you'll clearly see specific letter markings on it. We're talking H for high, M for medium, L for low, and EL for extra low. These tell you the exact pressure range of that specific unit. It literally dictates the resistance profile of those internal slits, determining exactly how much pressure it takes to open the pathway for the spinal fluid. But here is the catch, and it's a big one. Post-surgery, it is absolutely vital to know that this elastic tube between those valves is radiolucent, meaning it doesn't show up on an X-ray. Unlike some modern programmable valves, the Holter has 0 radiographic markings to tell you if it's a high or an extra low pressure valve once it's inside the patient's body. None. You can't just scan them, you have to rely strictly on the surgical operative notes.
Let's pivot to Section 4,
the salmon Rickham reservoir, and its unique design.
This watercolor diagram highlights exactly how this differs from a standard Rickham. It's got a much lower profile. The fluid sits right under this highly flexible celastic dome, which is exactly where you tap the device. And right beneath that fluid chamber sits a solid, rigid metal base connecting directly to the ventricular catheter line.
This design presents a direct clinical trade-off. That metal base is fantastic because it acts as a literal safety stop, preventing you from inadvertently pushing a needle too deep and wrecking the underlying tissue or catheter. But because of that low profile, the silicated dome up top is smaller. It's a tiny target. That means whoever is performing the tap has to be incredibly precise with their needle placement.
Finally, Section 5. Let's bring all this hardware knowledge directly back to the human element with uncompromising patient care instructions.
We absolutely have to nail these post-op protocols. First, patients must know the exact signs of a malfunction or infection. Second, and you'd be surprised how often this needs repeating, even though they have a literal pump under their skin, they must never pump it themselves unless a physician explicitly tells them to. And third, if they're getting a non-routine dental procedure, a cystoscopy, or a cystometrogram, they need prophylactic antibiotics. Those procedures can introduce bacteria straight into the bloodstream, which is a massive nightmare for the shunt hardware.
Also, if we're dealing with growing kids, you've got to evaluate the distal shunt length periodically. Kids grow tall fast, and if they shoot up, the peritoneal end of that catheter can literally pull right out of the abdominal cavity if not monitored. And lastly, families should always keep a smartphone photo of a normal, healthy baseline CT or MRI scan. If a patient shows up at the ER with a suspected malfunction, the attending physician desperately needs to see what their ventricles look like when the shunt is actually working to make an accurate comparison.
Which leaves us with a provocative final thought. As these device mechanisms become increasingly hyperspecific, from radiolucent tubing to complex gravity-actuated ball valves, isn't the informed patient's own access to their baseline visual data just as crucial as the hardware itself? It empowers the patient to be the definitive link in their own chain of care. I hope going point by point through this hardware has cleared everything up for you. Keep exploring, and I'll see you in the next explainer.